Forget frequently asked questions.
Common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
go above and beyond.
They become very good at what they do, but only
0.1%
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
with Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast. I have Paul Offit. He's a doctor, a director of the Vaccine Education Center. He's also a professor of pediatrics in the Division of Infectious Diseases at Children's Hospital of Philadelphia. He's also a Maurice R. Hilleman Professor of Vaccinology at the Perelman School of Medicine at the University of Pennsylvania. He's an expert, internationally recognized in the fields of virology and immunology. And we're going to talk about the race for COVID-19 vaccines. So, Paul, thanks for coming.
Thanks for asking me.
Yeah, obviously it's a topic of worldwide significance. Everyone says there's a big race on. In the media, I hear various scientific people saying it's going to take many, many years, and yet everyone seems to have the hope that it'll be soon. What's your overall perspective of the situation?
Well, it's unprecedented. I mean, never has a vaccine development program received this much international interest. So although typically, vaccine research and development program takes 15 to 20 years. This one, I think, reasonably will take only about a year and a half from actually having the strain to having a commercial product. The reason that's true is that you have more than 80 companies across the globe that are interested in making the vaccine. You have billions and billions of dollars that have been poured into this by the World Health Organization, Bill and Melinda Gates Foundation, the Health and Human Services. You have the unfortunately named Warp Speed program, which I'm sure scientists didn't name, but it's, now, that you're basically mass producing the vaccines at risk. You're making millions of doses without knowing whether the vaccine is safe or without knowing whether it's effective, which is really what we did back in 1955 with the polio vaccine program. And, it's going to be probably a less extensive licensure process. This is going to be released through the emergency use authorization. So the FDA, I think, has to some extent a lighter touch here. But I would say this: I think as long as we do phase 3 trials, as long as we do the phase 3 trials that the NIH active group is asking us to do, which is to say 30,000 people in a prospective placebo-controlled trial, 20,000 vaccinees, 10,000 placebo recipients, as long as we do that, then there's a catchment for all of this rushing.
Okay, so quick question here. Phase 3, you're saying the cohort would be 30,000 people, 20,000 unvaccinated, 10,000 not, and then they would be deliberately exposed to COVID to see if they develop antibodies or if they get sick?
It would just be done in nature. In other words, you would hope that you would pick spots where the virus is circulating so that there would be a reasonable number of people in the placebo group that got infected or got sick. But these aren't human challenge studies. These are just sort of natural challenge studies.
Well, I mean, based on the scale of the problem and the trillions of loss, why not ask for and get a special ethics cutout for humans to get these vaccines or not, and to be deliberately exposed to a very likely exposure of COVID? That would make the data a lot more robust. Yes, there would be 30,000 people that would have to give their consent, but I bet you if they were paid, they would.
It's not as easy as it sounds. I think ethics is not really the issue. I think ethicists have generally weighed in on this and said, basically, since this virus is killing 500 to 1,000 people a day, it would be reasonable for people to volunteer under consent to be experimentally inoculated with SARS-CoV-2. It's not that easy. What you have to do, first of all, is you have to get the dose right. You have to try and mimic the natural situation, and nothing mimics like the natural situation like the natural situation. So if there's a fairly high infection rate in the wild, if you will, and sometimes that's easier because you have to get the dose right. Also, remember, the virus that you're giving is virus that you've experimentally grown up in the laboratory, and you always run the risk of having changes in that virus that are distinct from that which is occurring in the wild. So in many ways, I don't think it's any faster actually to do human challenge studies. It's probably going to be just as fast to do this in the wild. And initially we thought this is not going to be easy in the summer months because these kinds of respiratory viruses spread by small droplets disappear in the summer months, but that's not true of this virus. This virus is raging in the United States in the summer. So in many ways, these may not be hard studies to do.
Well, so what would the study look like then? You would vaccinate 20,000 people and then pretend to vaccinate, or give a dud to 10,000 people and then say, all right, go home and we'll have you report how you feel over the next 2 weeks, or like, how would it work?
Yeah, exactly that, except not 2 weeks, probably more like several months. And you do work against yourself at some level because you want to make sure that people, wash their hands, wear masks, maintain social distancing. So in some ways, you're going to be advising your placebo group not to get sick, knowing that really you at some level want them to get infected, want them to get sick so that you can make statements about efficacy. But I think with the kind of attack rate that we're getting, not only in this country, but also in some other places in the world, and the world is going to be the site where these trials are done, I think we probably could generate a reasonable amount of data in 6 months or so.
Well, if you have a certain size cohort, that means that the statisticians would have to know that is enough people to get a statistically relevant result, which means that they should know the implied infection rate.
Right. And so I think they do, hence the 30,000 person trial. I think also remember the Data Safety Monitoring Board will be involved in every one of these trials. And so they'll always know who's gotten the vaccine and who's gotten the placebo. So you'll be able to tell very quickly, one, whether there's a safety problem, and two, whether the vaccine is clearly effective, in which case, you can stop the trial early.
So your estimation would be that there'll be maybe approximately, you said there's about 80 companies. Would it be safe to say there might be at least 20 trials of this scale that go on in the next year or two?
Yes. And I think the trials, at least in this country, are going to involve messenger RNA, replication defective human adenoviruses, vectored vaccines, similar to the Merck's Ebola virus vaccine. But what we're not moving forward with are basically strategies with which we have a lot of experience, like an inactivated viral vaccine or a live attenuated viral vaccine or a purified protein viral vaccine. I think we do have one purified protein viral vaccine, which is the Novavax vaccine. I mean, all are geared towards making antibodies, to the SARS-CoV-2 spike protein, specifically to the receptor binding domain of that spike protein, in the hopes that that'll prevent the virus from binding to cells and infecting cells and therefore prevent disease. But we'll see. I think, for all the hype that surrounded, each of these very small phase 1 dose ranging studies, where we handle these stories like, we've been handed the Holy Grail. We really do have to wait for phase 3 trials. And I do worry that this administration might be tempted as we move toward, the election to sort of reach their hand into the warp speed bucket, pull out a couple of vaccines, say, look, these have been tested in thousands of people and it looks like they certainly are safe. And we have these great immune responses. And so we're really sure that this is going to be protective. This is going to be the biggest breakthrough in the history of medicine. I do worry about that because, as you know, it's often true that it's hard to get an immunological correlative protection. So just because you have a good neutralizing antibody response in your circulation, that doesn't necessarily mean you're going to be protected, which is why you have to do efficacy trials.
So where are the trials happening? Are they happening mostly in the U.S.? And, you talk about this administration, this country, but what about all the other countries of the world? Why aren't any of them putting themselves forth as big leaders or proponents of making a vaccine, leading the charge?
Well, they are. I mean, China certainly is, and the Beijing Research Institute is moving forward. The UK group, the Jenner Institute at the University of Oxford, is moving forward with their replication defective simian adenovirus. So there are other countries that are moving forward. Well, I think China is working on also an inactivated vaccine as well as a replication defective human adenovirus 5 vector. Cogenics is a company that's working with Serum Institute of India to make a live attenuated viral vaccine. So all strategies that have ever been used before to make a vaccine are being made somewhere in the world. And, certainly these novel strategies are being made not only in the United States, but elsewhere in the world. So that's what makes this so unique and why we probably could get a vaccine fairly.
Are the novel strategies being used in the U.S. and the common tried and true ones not? Or just very little? Or is worldwide are mostly novel strategies being used?
I think worldwide, mostly novel strategies are being used. I mean, here, the warp speed vaccines are novel strategies vaccines, mRNA by Moderna or Pfizer. The the vesicular stomatitis virus vectored vaccine, which is similar to the Ebola vaccine that is Merck's product. And then you have J&J's product, which is replication defective adenovirus 26. And so the products here tend to be these novel strategies.
Well, why? If the goal is to make something that works, why not include a healthy, pun intended, dose of tried and true strategies? Why focus mostly on novel things, which could add to the complexity and make it less likely that you get a breakthrough?
Yeah, I think that's happening. I mean, the initial contracts that were signed for warp speed were these novel strategies because they're the fastest to make. They're basically plug and play vaccines, meaning the protein you're interested in. It's the spike protein. You know the gene that defines that spike protein. So it's very easy to plug that gene into messenger RNA, into DNA, into replication defective viruses, whether simian or human. So and they're very easy to scale up. So they're easy to make and easy to scale up. And so they're the fastest. You're right. That doesn't certainly necessarily mean they're the best. And I think that we will, this isn't going to be the end of it in the United States. I think we are going to be contracting with other companies like Novavax, which is making the purified protein vaccine. And I think as we move forward, I suspect we're also going to be looking at an inactivated vaccine.
So what are the parameters on success? How efficacious does it need to be? How long should it confer immunity?
Well, you'd certainly like to have protection against moderate to severe disease in the 70 to 75% range. I mean, I think it's reasonable to expect that that you will have short-lived and incomplete protection. By short-lived, I mean it might only last a year or two. By incomplete, I mean protection against moderate to severe disease, but not necessarily mild disease associated with infection. That would be reasonable enough. I think that would help to get us out of this. If you had, there's a formula, as you know, for figuring out what percentage of the population needs to be immunized. It's based on two facts. One is the contagiousness of the virus, and two is the effectiveness of the vaccine. If you had a vaccine that was 75% effective, you'd probably need to vaccinate about 2/3 of the American population to stop spread.
Okay, so those are the parameters. I had thought that, I don't know if it was the FDA or CDC was only looking for like 50% efficacy. Were they just trying to get something on the board, or what's typical?
Yeah, I think that when the NIH Active Group, which was put together by Francis Collins to try and help to facilitate or accelerate the development of a vaccine, when they were initially coming together with their sort of statistical model, they sort of set a baseline efficacy, and that baseline was 50%. Somehow that got picked up at the media as that's what we were aiming for. No, I think that we just would aim for nothing less than that. I don't see why we can't have a vaccine that's about 75% effective. That's what Dr. Fauci said, and I think he's right.
What do you think is going to happen with flu coming? I don't know it seems like flu surveillance is even itself on the back burner. Do you think there might be, I don't know, is anyone accounting for the possibility of co-infection with flu and complications because of that?
Sure. In many ways, last year, we were lucky, if there's anything one can say about this that's lucky. Influenza last year in the United States caused more than 50 million cases, caused about 780,000 hospitalizations, and caused about 60,000 people to die. And that's not trivial. Somehow that gets just grandfathered in. I was on a call earlier today out of KQED in California, and one of the questioners said, just the common flu, the routine flu. Flu can kill. And as the virus started to come into this country, our first death was at the beginning of March, and then it started to take off. That's when flu was starting to taper off. This year coming up, if SARS-CoV-2 continues to do what it was doing last year, and flu does what it does every year, which is cause disease, in the winter months, you could see these infections happening at the same time, which I think could very easily overwhelm the healthcare system. And then the point that you brought up is a good one. Will we also face what would be an unusual co-infection, which could present in an odd way?
Well, perhaps it could be the opposite. Perhaps people that get sick with flu will somehow be protected from SARS-CoV-2, and the opposite. It seems like for some reason, infecting parasites and other organisms, treat us like a kombucha. They want to set up shop and push out everything else. So there might be a beneficial effect somehow that way. I don't know.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
Yeah, I mean, the phenomenon of paraimmunity, non-specific immunity, it's true. If, for example, probably the most data on this are with BCG, the tuberculosis vaccine, is that when you give the tuberculosis vaccine, you induce interferon, which can interfere with, which is where it got its name, interfere with the capacity of viruses to infect. There was some data for this also with measles-containing vaccine and with the oral polio vaccine. So, Robert Gallo has talked about this a lot and has written about it in the New York Times. Is sort of, why don't we do this? Why don't we look for paraimmunity? And in fact, in Southampton in the United Kingdom, they're giving interferon as a treatment for just that reason, this sort of non-specific effect that when you are responding to influenza, you also make an interferon response, which can interfere with other viral infections. So that might, I guess we'll see.
So you mentioned several times there's a lot of novel methods for vaccine, and you ran over them really quickly. I'm only barely familiar with them. Can you go into a few of the novel mechanisms and how they work?
Sure. So the
might work.
Yes, sure. The one that probably is that most people hear about is so-called messenger RNA. So what you do is you basically take the messenger RNA that is responsible for coding for the coronavirus spike protein. You put it in this complex lipid delivery system. You inoculate it into the arm, and then that messenger RNA is taken up into the muscle, where it is then translated to the protein, the coronavirus spike protein, and then you make an immune response to that protein. So basically, you make the coronavirus spike protein, and then you make an antibody response to that protein. The same thing's true for the DNA strategy, where you inoculate with DNA that codes for that protein, but now the DNA first has to be transcribed to messenger RNA, then it has to be translated to that protein, the spike protein, so it's sort of a step away. Then you have these so-called replication-deficient adenoviruses. So adenovirus, as you know, is the cause of colds as well as a variety of other symptoms. They make it replication defective, so it can't reproduce itself. It can't cause disease, the adenovirus itself. But it's genetically engineered so it can make this one protein you're interested in, again, the spike protein. So the virus enters the cell, makes that protein, but doesn't reproduce itself. The issue with that is you have to give a lot of virus particles for a virus that's not reproducing itself, somewhere in the order of 50 billion virus particles. And when you do those things, you get side effects like fever, headache, chills, muscle aches. So, which is also true with the mRNA vaccines as well. So those are basically the replication deficient strategies. And then there's the so-called vectored vaccine strategy, where you take a virus that's not a human pathogen, and although it reproduces itself, it's kind of an orphan virus. It doesn't cause disease. It's like vesicular stomatitis virus, which is how the Ebola virus vaccine is made. And then you clone into that or transfect that or genetically engineer that more accurately with the gene that codes for the spike protein, and then you give that virus. And that's the way the Ebola vaccine was made. So those are all novel strategies with which we have little experience in the United States, and I'm sure there's going to be an enormous learning curve associated with this. So you're right. I mean, you have, on the one hand, this elusive, difficult to characterize virus, which has already really surprised people in a lot of ways. I mean, that it causes this so-called multi-inflammatory systemic disease in children, that it rages in the summer months, that it causes a disruption of endothelial cells that line blood vessels and causes basically a vasculitis that can lead to things like COVID toes, which is like frostbite. I mean, these are all surprising findings, and we're just getting started. This virus is only 7 months old. So you're meeting this difficult, kind of elusive, surprising virus with vaccine strategies that have never been used before. I mean, I think it's fair to say we're going to learn things over the next 2 years that we wish we knew now.
Yeah, definitely. In terms of SARS-CoV-2 itself and our current understanding, it appears to be a lot less changeable. I don't know the word for it than flu. I mean, flu, we need vaccine every year because it just changes so much. So, what are some of the good and the bad characteristics of SARS-CoV-2 in regards to a vaccine and how efficacious it might be?
Right. So SARS-CoV-2 is a single-stranded RNA virus, like influenza, like measles, like mumps, like German measles, rubella. And so like all single-stranded RNA viruses, it does mutate. With every cycle of replication, these are single-stranded RNA viruses aren't terribly faithful when they reproduce. But the issue is not, does this virus mutate? It mutates. Measles mutates. The question is, does it mutate in a functionally important way? In other words, to become more contagious or less contagious, to become more likely to cause severe disease or less likely to cause severe disease. And then more importantly, like influenza, does it mutate so much from one year to the next that natural infection or immunization 1 year doesn't protect you the following year. I don't think it does that. I don't think it's going to mutate away from the vaccine, although I should stop making predictions about this virus because I'm always wrong, but I'm still going to make that prediction and probably be wrong here too. It does seem to be able to have mutated. There's this sort of D641G mutation that seems to have been associated with increased contagiousness. I guess we'll see how that plays out, but that does seem to be true. But it doesn't seem to mutate to become more or less virulent, more or less likely to cause severe disease. So we'll see how this plays out. But I think it's going to end up being more like measles than flu.
Well, okay, so you say it's more like measles than flu. I remember getting the MMR, vaccine, and that's supposed to last you years and years and years. So you're saying that your prediction may be that we might not need a vaccine to SARS-CoV-2 every year?
Yeah, no, I think we won't. This vaccine will not mimic measles vaccine. Measles vaccine is amazing. I mean, you get 2 doses of measles vaccine, you basically have 97% efficacy for the rest of your life. That's not going to be this. And it's true for all sort of relatively short incubation period respiratory viruses. I mean, I think if you can get protection for a year or 2 or 3, that would be great. You could have protection that's as short as just 1 year. I mean, there were studies done in the early 1990s with human coronavirus doing challenge trials showing that of the 4 serotypes of human coronavirus that circulate every year in this country, if you're infected with one serotype and then a year later challenged with that same serotype, you're generally protected. So that's encouraging that at least protection in that study lasted for a year. I hope we can get protection for a year with this. We'll see. Worst comes to worst, you would boost the following year. But even if you can just get protection for 6 months, 8 months, 9 months, that would go a long way to trying to stop the spread of this virus.
Yeah, since the common cold and other coronaviruses, have been around us for countless numbers of years, I've seen some articles that seem to say that may confer some subset of immunity or some, light immunity because of our exposure to them. Do you think that's possible?
There does seem to be a cross-reactivity with T helper cell responses. So there may be some advantage to that. Still, I think that if we're going to get any sort of long-lived specific immunity, it's going to have to be with a vaccine. That's the only way we're going to stop the spread of this. Natural infection is not going to stop the spread of this. I think previous experience with human coronavirus is not going to stop the spread of this. So we need a vaccine. We need a safe and effective vaccine. And we need to go through the process the way we've been going through the process the last 70 years, which is to say, do a phase 3 trial. Richard, I can't tell you how nervous I am about this administration not doing phase 3 trials, because let's suppose the following happens. Let's suppose that the UK group does a very small phase 3 trial, not the kind of trial we would normally do in this country, and then they put it out in the UK market. I mean, would we want to do the same thing here, accepting really a lesser bar for what we would normally do? And that's what worries me. It worries some of the companies too that may play out that way.
Well, phase 3 trials. Have any companies finished phase 2? Like, what does phase 2 look like? And when do you think the first phase 3 will begin from any company?
Phase 3 trials have already begun for starting this months. So I think of all the phases of a typical vaccine program, I think phase 1 trials have tended to be much smaller than are typically done. Phase 2 trials were largely getting skipped. I mean, you look at that New England Journal of Medicine paper with the Moderna vaccine. I mean, that was basically a study of 15 people who got the 100 microgram dose. They're going to start at the end now, if not the end of this month, their phase 3 trial. And same with a variety of other companies. I mean, if anything has been sacrificed here, it's the phase 2 trial, which is to say you do hundreds of people to make sure that your vaccine is consistently safe and consistently immunogenic, so you can at least say it doesn't have a common side effect problem, and that you expect when you go to phase 3 that it's going to be consistently immunogenic. We'll see. It's interesting that when they did a poll recently, both ABC and another group did a poll, they asked, people, would they get a COVID-19 vaccine? And, the New York Times wrote an article of this. I was on CNN yesterday talking with Brian Todd about this on Wolf Blitzer's program. 2/3 of people said, between 50% and 2/3 of people said that, would you get a COVID-19 vaccine? And they said, yes. That's pretty amazing, actually. They tried to spin this as, look, a third of the population is not going to get the vaccine. I think the fact that 2/3 of the population would get a theoretical unknown vaccine for which you have no data against a virus which has been at best elusive, I think is pretty amazing. I mean, I think I would have answered no to that question. I want to see the data first.
Well, I mean, unfortunately, it's become politicized, so any answer anyone gives could be twisted to make them look bad. So, I mean, who knows? I could say, well, the media has done such a good job of instilling fear, right or wrong, that it's no surprise that many people want it. Or I could say, all kinds of things. So I understand, but I just don't know what to do with that data point. I did want to ask you a question. So how do vaccines go wrong? Like, you keep talking about you hope, and you hope that things are done in the right way. What does the wrong way look like? What happens if there's a failure?
Well, I think when you do a phase 3 trial, what you do is mitigate risk. You can say, look, I vaccinated 20,000 people. I can say there's not an uncommon side effect. But I don't know whether there's a rare side effect. 20,000 people isn't 20 million people. So you've mitigated the risk to some extent. You can do an efficacy trial that will tell you that it's effective at a certain level of efficacy. It's say 70, 75%, but you don't know for how long. That you're only going to find out afterwards. So I think the goal is to manage expectations, to make sure that when the vaccine rolls out, that people know that it may have a rare side effect you don't know about. It may have an efficacy that's shorter lived than you had hoped. And, this happens all the time with medical products. You never really know till you put it in lots of people. Maurice Hilleman, who I think was the father of modern vaccines, having either done the primary research or development of 9 of the 14 vaccines we currently use today, he said it best, quote, "I never breathe a sigh of relief until the first 3 million doses are out there." That's always true. And so, the dengue vaccine was only found to be to increase your risk when you then were confronted with natural infection, so-called antibody-dependent enhancement, when it was in thousands of people after it was already licensed, and accounted for deaths in some children. The rotor shield vaccine, was found to be safe pre-licensure, but was found to cause intussusception post-licensure. The 1976 swine flu vaccine was found to be a rare cause of Guillain-Barré syndrome. You learn as you go, and invariably there is a cost to that knowledge.
And then also today we have, I guess, what's called the Antivaxxer movement. So I'm sure that'll have its say in this, regardless of the outcome. But,
you can count on it. This is going to be a SARS-CoV-2 vaccine that will be designed to prevent SARS-CoV-2 and not everything else that happens in life. They will be right there with, got a vaccine, 2 days later had a stroke, had a heart attack, had first symptoms of multiple sclerosis, now is diagnosed with diabetes, whatever it is. They'll be there all over the news and social media with those stories. But, there's no convincing them. They're conspiracy theorists. What I worry about are the people who are in any sense influenced by them. And, I think you should be skeptical about anything you put in your body, including vaccines. I just don't think you should be cynical, which is what this group is.
Well, how do you weigh the benefits versus the cost of a vaccine, the upside versus the downside? What's that calculus look like? I know it depends on everything, but, what's a common calculus for vaccines in the past or this one that's coming?
Well, it always has to be weighed against the benefit. When, this is a virus that's killing 500 to 1,000 people a day, that's the benefit. So there's an enormous benefit. But, like any medical product, vaccines are not risk-free. And so, there's always a certain amount of uncertainty. You try and lessen that uncertainty in the phase 3 trial, but you don't eliminate it. And you just have to make sure that there are systems in place to pick up problems when they occur. And you have to make sure that you get the public understands what vaccines, this particular vaccine or these vaccines can and don't and may not be able to do. You just have to manage those expectations. But I think people expect breakthroughs without a cost, and that's historically, in the history of medical breakthroughs, never been true.
What about antivirals? Why just vaccines? Why not antivirals? Why is there not much talk about them?
Well, first of all, an ounce of prevention is worth a pound of cure. I'm at the University of Pennsylvania. We're supposed to give at least one Ben Franklin quote in every talk we give. It's much better to prevent something than treat it. And, and antivirals, I think, have a value as long as you're catching the disease at a time when viral replication is the most important part of pathogenesis, which is really very early in the infection. Usually people aren't identified that early, and so you're treating them later, which is why antivirals aren't generally wonder drugs. In the case of SARS-CoV-2, remdesivir was shown in an NIH trial to decrease your length of time of infection from 15 days to 11 days. So that's some value, but it didn't really save your life. There was no evidence that you were less likely to die with remdesivir than not. Probably because at the time that it's given, you were a little too far along and viral replication wasn't as important of the part of pathogenesis as your immune response was. So that's the problem with antivirals.
So what are some possible scenarios over the next 6 months and the next year? What do you think may be likely to happen?
I think early next year, there will be one or two or more vaccines that will roll out. I think that they'll roll out relatively slowly because if you're talking about trying to vaccinate just the high risk groups, the groups, specifically people who work in healthcare, African Americans, people who are elderly, especially with comorbidities, people who work in nursing homes, meatpacking plants, grocery stores, pharmacies, these are probably going to be 2-dose vaccines separated by 1 or 2 months. And if you just take the high-risk groups, according to the Advisory Committee for Immunization Practices, that's probably about 120 million people with a 2-dose vaccine. So you're talking about 240 doses of vaccine. That's not all going to be made at once. And I think it's going to just have to, get out there in non-traditional sources. Like it can't just be in the medical home. It can't just be in a doctor's office. I don't think you're going to be able to do that. So it has to be like flu vaccine in some other ways, like pharmacies or hospitals. I mean, I get my flu vaccine every year in the hospital, and we'll see. I do worry about this a little bit too. I mean, this is an administrative initiative, which is to say, this is the same administration that hasn't been great about providing face masks or PPEs, that hasn't been great about testing and contact tracing, that hasn't been great about even just defining for the public just what hygienic measures need to be done until more recently. And this is the same administration that's going to be charged with implementing and distributing this vaccine. And you do worry about it. It's not an easy thing to do, especially now.
Do you think that there's going to be a vaccine requirement? A passport that people are going to need to be vaccinated in order to be able to do things, or do you think it's going to be first provided to the high risk groups?
I think it'll first be provided to high-risk groups. I think the notion of a passport is a little silly because it would make the false claim that just because you've gotten a vaccine means that you're protected. If you've gotten a vaccine, that means you're more likely to be protected, but you're not necessarily protected. And I think the same with mandates. I don't think you could mandate this vaccine coming out. First of all, I don't think you would be able to. You're not going to have enough vaccine as it is. And, you're really going to learn as you go with these early vaccines. So I think that's another reason you shouldn't mandate.
Well, I mean, for instance, Bill Gates has made a public statement saying, the world will not return to normal unless most of the world, or maybe all the world's vaccinated. So that does seem to say that this will be different from other vaccines, and that there may be pressure for everyone to have it, regardless, and to rely upon it as now being safe once you've had it.
Well, he's right. I mean, I think the world will only return to normal when a critical number of people get vaccinated. I don't think it's going to have to be everybody. I think we can stop spread without having everybody vaccinated, as we do with all vaccines. Remember, some people can't be vaccinated because they're immune suppressed or whatever reason.
So what do you think will happen if more than one vaccine comes out at the same time? What kind of competition or interplay will it be?
Yeah, that's a great question. I think it may depend on sort of to what degree different vaccines are effective against different subsets of people. I mean, hopefully these vaccine trials will include all those subsets who are likely to be in the priority group when it rolls out. And you may find that one vaccine or another works better in different populations. And so we'll see that. And then we'll just see what happens when it rolls out. I think we're going to learn a lot sort of post-approval as to how effective these really are, how long-lasting they are, how safe they are. I think, you're going to learn more when millions and millions of doses are out there.
Yeah, you spoke earlier, we're just about out of time, but you spoke earlier about flu and the number of hospitalizations, the number of cases, the amount of death, et cetera. But the response to this, I guess a lot of it is because it's novel, is, far higher than it was to flu, than far higher it's been to other conditions. How do you think people are going to treat and react to SARS-CoV-2 in the future? Are they going to get used to it and it'll become part of life and there won't be such concern over it? Or how do you think this is going to play out mentally, and how countries operate?
Yeah, I think we're probably going to get to a point where there's a certain number of cases that are reported per day, or a certain number of deaths that are reported per day or per week or per month, that is low enough that we then feel comfortable again. I mean, it's interesting how we're perfectly comfortable with flu, which killed 60,000 people in America last year, and yet somehow that's all grandfathered in. This virus has done more than twice that, but it's not like out of the range. It's not like logarithmically different. They're both killers. It'll be interesting to see what happens this year when we, no doubt, will still be wearing masks as we enter this winter and still be trying to social distance. And it'll be interesting to see what happens to the incidence of flu this year.
Yeah. Well, very good. Paul, what's the best way for people to find out more about your work and your thoughts?
What is the best way? I guess, I have a Twitter site, which I don't really do all that much. It's called @PaulOffit. I do have a Facebook page, which, gives you a chance to tell me how much you don't like me. There's that. And, otherwise, I think that's better. I do write books. So I wrote a book recently called Overkill: When Modern Medicine Goes Too Far. So actually, it's funny, I have to be on CNN at 5 with Wolf Blitzer. And, I'm going to be the guy on CNN who doesn't prominently display his book behind him. Okay, just so you know, that's me. Because everybody else does that. Do you know what I'm saying?
Well, I'll give Wolf a hug for me. I'm just kidding. He doesn't even know who I am, but that's really cool. Excellent. Right. Well, Paul, thanks for coming. I appreciate it. With places like CNN that want to interview you, thanks for hanging out with me too. And I appreciate you being here.
Sure. Well, I know you and like you. I don't know Wolf Blitzer.
Well, hopefully he'll be friendly to you too. So.
All right. I guess we'll see. All right, Richard. Take care.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed.